Good afternoon, everyone, and happy Friday. I hope you all are getting ready for the weekend. Looking forward to that. A couple of housekeeping things as we get started today. Everybody will be muted for the duration, and your cameras will be turned off for the duration of the webinar. If you would like to make comments or ask questions, feel free to put those in the chat, and I will attempt to monitor that during the course of the webinar and answer any questions either throughout or at the end. I will certainly save some time. So feel free to put those questions in that chat or make your comments there as we go along. So today we are talking about trauma-informed addiction treatment, and we're going to take a little bit of a deep dive into this concept of trauma-informed and what that means really in practical terms for our work in the addiction world. So let's get started. So some objectives. We're going to talk about the core principles of trauma-informed care and how to apply them to our work in the addiction field. We're going to talk about addiction and trauma in particular, how they're related, and understand their impact on the brain and behavior. And also talk about adverse childhood experiences and how that impacts our work with clients as well, and our trauma-informed approaches. I'm going to attempt to not cough throughout this. So let's start with what is trauma. In general, trauma is used as a very kind of umbrella term and results from an exposure to an incident or series of events that are emotionally disturbing or life-threatening that have lasting adverse effects on the person's functioning, mental, physical, social, emotional, and/or spiritual well-being. So it can include a variety of things and a variety of experiences, and really just has to do with does the person have these lasting adverse effects on their functioning and well-being based on the trauma they experienced. So it can be things like physical, sexual, or emotional abuse, neglect, living with a family member that's had mental health or substance use disorders, a sudden or unexplained separation from a loved one, poverty, racism, discrimination, and oppression, violence in a community, war, terrorism, can be natural disasters, as we know here in Louisiana, and anything else that can be, disturbing emotionally to somebody and/or life-threatening that would kind of cause these lasting adverse effects. So really, we're looking for the person to identify what is traumatic to them and be able to work from there in our work that we do in the addiction space. So one tool that we have to use now is the Adverse Childhood Experiences Scale. And we're going to go through that in a moment. But one of the things that is important about this is that this can be used as a tool to help us figure out if somebody's experienced trauma. So sometimes people don't necessarily identify that they've experienced trauma themselves, but we can use this tool to help identify if they have gone through some traumatic experiences and if that could possibly be impacting what's going on with them present day when we're treating them in our work. So the ACEs scale is a 10-question scale that asks about a variety of issues from childhood. So things that have happened to somebody prior to their 18th birthday. So we're going to go through these very quickly, just so you have a feel for them if you haven't seen this tool before. So number one, did a parent or other adult in the household often or very often swear at you, insult you, put you down, humiliate you, or act in a way that made you feel afraid or that you might be physically hurt? So this one's getting at verbal abuse. Secondly, did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, ever hit you so hard that you had marks or were injured? So physical abuse. Did an adult or a person that's at least 5 years older than you ever touch or fondle you, touch or Okay, touch or fondle you, or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you. So sexual abuse. Did you often or very often feel that no one in your family loved you, or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? So talking about neglect there. Did you often or very often feel that you didn't have enough to eat, had to wear dirty clothes, had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if you needed it? So again, some neglect there as well. Were your parents ever separated or divorced? So that could speak to a separation from a parental figure. Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her, or sometimes, often, or very often kicked, bitten, hit with a fist, or hit with something hard, or ever repeatedly hit over at least a few minutes, or threatened with a gun or a knife? So speaking of intimate partner violence or domestic violence that was witnessed. Did you live with anyone who was a problem drinker, alcoholic, or used street drugs? With a household member depressed, mentally ill, or did a household member attempt suicide? So mental health issues, substance use issues. Did a household member go to prison? Again, a separation of a parental figure. So these 10 questions are given each a point if they're answered with a yes. So you just add up the points that somebody, if they answered in the affirmative, and that's your ACE score. So you can have up to 10. You can have 0 up to 10, basically. So let's look at the prevalence rates here. 62% of US adults have at least one ACE score. So at least one of those things out of those 10 questions, they answered yes to. And about 25% of US adults have 3 or more ACEs. So basically what this is saying is that a lot of people that we're going to be treating, whether we're treating mental health related issues, addiction related issues, no matter what realm of the healthcare continuum of care that we're working in, that we're going to see a lot of people, over half, that have experienced some kind of trauma from childhood prior to their 18th birthday. And that doesn't really even account for people that have experienced trauma in adulthood. So this is just things that they've experienced from childhood. Now, based on the ACEs score, people that have 3 or more ACEs are 2 times as likely to smoke, 2.5 times more likely to have sexually transmitted infections, 4 times more likely to have chronic obstructive pulmonary disease, 7 times more likely to consider themselves an alcoholic, 10 times as likely to have injected street drugs, and 12 times as likely to have attempted suicide. So I think what this is telling us more than anything is that people who've had multiple traumas prior to their 18th birthday have a lot of risk factors among the continuum of healthcare. So we've got mental health related issues, we've got physical health related issues, we've got alcohol or substance use issues as well. So what I think another thing this is telling us is not only are there a lot of risk factors, but we really do, when we're working with clients that have mental health and substance use issues, that we kind of have to take into account that they probably did experience some trauma, particularly from childhood. And they probably experienced some trauma throughout the course of their addiction as well. That's pretty common also. So it's almost like we need to look at every client that we serve as someone who's probably experienced trauma. So it's not an exception, it's more the rule now that we have this data to look at from decades of ACEs research that's been done at this point. So specifically looking at addiction and ACE scores, that women were 50% more likely than men to have experienced 5 or more ACEs. So 5 or more of those adverse childhood experiences. And the higher the ACE score, the higher the chances of addiction to alcohol and other drugs in adulthood. So it's a pretty big risk factor. The more ACEs, the higher the ACE score, the higher the chances there. For more ACEs, there's a 500% increase in the risk for adult alcoholism. Men with 6 or more ACEs, 4,600% increase in risk for IV drug use. And 78% of IV drug use in women can be attributed to adverse childhood experiences. So this has a lot of implications for our work in the addiction space. And being able to come at all of our clients across the board from a trauma-informed perspective becomes much more important, because they are so likely to have had adverse childhood experiences in childhood, but also some traumas as adults as well. So let's talk about the brain. Looking at PTSD and trauma and what areas of the brain are affected by PTSD, we can look at, in this blue section on the top left of your screen, the prefrontal cortex, which controls abstract thinking, our personality development, behavior regulation, planning, and problem solving. And there, that little red space kind of in the middle towards the bottom of the brain, towards the brain stem, is the amygdala. This is responsible for decision-making, emotional memories. It regulates our behavior and initiates responses to fear. Then right to the right, that little pink area next to the amygdala is the hippocampus, which is responsible for memory consolidation, navigation and spatial memory, and learning. So if PTSD is really impacting these 3 areas of the brain, we can see that, and we'll talk about how addiction affects the brain, but I'm going to give you a little bit of a clue here. It affects basically the same areas. That, addiction and trauma go hand in hand with how it affects the brain and affecting these areas. And so we kind of have to take into account that trauma is a part of our work with addiction, and we're working in mostly the same areas of the brain as we would work with just trauma or just addiction alone. So integrating them is maybe perhaps a little bit easier than we thought, but also can be challenging because of those impacts to the brain. And, if we can look back at our ACEs scores, those adverse childhood experiences, how they impact a developing brain, and how each of these areas are impacted from such an early age, can really cause some significant issues later. And also, as we know from the research, can lead to addiction. So let's talk about addiction briefly. I think we all know a lot of this, but just as a recap for all of us to make sure we're on the same page, that the National Institute on Drug Abuse is where I got this definition, talking about the disease model of addiction. That addiction is defined as a chronic relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. It's considered a brain disease because drugs change the brain. They change the structure and how it works. So let's look at the brain. So you can see a before and after slide here. Before substance use and addiction, you see all these connections and how the executive function over here and the prefrontal cortex area, that they all communicate with each other, and it's kind of this nice sending information back and forth to each other at kind of a same rate. And then what happens after substance use, we see that the pleasure-seeking elements get much bigger. We see the hippocampus here, the amygdala. We see, these are all much, much bigger. And that pleasure-seeking overrides reason and takes over our motivation and drive. So former strong connections, you can see this little arrow right here, former strong connections between judgment and motivation start to shrink. And as the addiction becomes more and more prevalent in someone's life, this judgment and motivation continues to shrink, and this pleasure seeking continues to override reason. Excuse me. Okay. So what we're talking about today is trauma-informed care. Goodness, I'm so sorry. So what is trauma-informed care? Of course, I've been fine all day, and here I am on a webinar starting to have a coughing fit. Okay, so what trauma-informed care is really asking us to do is to shift our focus from a question of what's wrong with you to a question of what happened to you. So it's a subtle shift, but it can be significant. So we're taking into account, and we're kind of assuming that something has happened to this person that's before us. And it's not necessarily that something is wrong with them. We just need to take into account their life experiences that may be impacting what's going on with them from a healthcare perspective. So what a trauma-informed approach to care acknowledges is that our healthcare organizations and us as professionals, as a part of healthcare teams, that we need to have a more holistic and complete picture of the client or patient's life situation, both their past and present, in order to provide really effective healthcare services that are focused on healing. So, kind of this concept of integrated healthcare comes into play here, that if someone is coming to see me as a counselor, that I can, of course, evaluate their mental health related issues and their substance use issues, but also, if something traumatic physically happened to them, then I would want to perhaps refer them to a medical professional that can assist them with physical health related issues. And I continue to treat mental health and substance use. And I work with that provider that's doing the physical health to be integrated in our approach with this person and help them navigate. And understanding that someone with physical trauma may have trouble engaging with a healthcare provider that works with them on their physical issues. That may be re-traumatizing for somebody. And so how can I work with this client to help them get prepared, perhaps to go see their medical professional? Or how can I coordinate with the medical professional to make sure that this client of mine has a good experience? It kind of makes us think outside the box a little bit and integrate care in a different way. And recognizing that someone with trauma, that first of all, the person sitting before us is likely to have trauma, and helping them navigate the healthcare system and getting holistic and integrated care can sometimes be challenging. And what can we do in our role to help manage those challenges and help that person be prepared and navigate some of, just our healthcare system and how it works and doesn't work sometimes. It also asks us to adopt trauma-informed practices in the workplace with staff, all levels of staff, and the treatment that we provide and the environment we provide. That it's asking us to adopt these practices because it can improve patient engagement, improve their treatment adherence, their health outcomes, as well as our own provider and staff wellness. It's important for healthcare providers to also be well. and we talk about things like burnout or vicarious trauma or secondary trauma, that can have impacts on our wellness as providers and staff. It can also help reduce avoidable care and excess costs to our health system for both the healthcare system, just bottleneck that sometimes we get in like emergency departments is a good example, as a good place where people access care, and our social service sectors, getting people connected to the right resources in the community. This website at the bottom, the Trauma-Informed Care, this website is dedicated to helping organizations implement trauma-informed care approaches. And there's tons and tons of resources for us as providers, for our organization to change things organization-wide. But it's not necessarily geared towards patients or clients. It's mostly just geared to the organization and the providers and how to kind of change culture to be more trauma-informed in our healthcare settings. So this is a great website to jot down and use, because it's got a lot of wonderful resources, and I put some of them in this presentation today so you get a feel for it. So what is trauma-informed? Like, what does that actually mean? So let's break it down. We've got 5 different qualities, perhaps, or principles, it's probably a better word, of what it means to be trauma-informed. So first, we're looking for safety. We're ensuring physical and emotional safety for the clients and patients that we serve. So looking at things like waiting rooms. What does your waiting room look like? Is it welcoming? Or does it look like a dungeon? What's on the wall? What art is on the wall? Is it private? Or is there a ton of windows that everyone can see who's sitting in your waiting room? Is confidentiality respected at the front desk? Or is it open? Kind of everyone in the waiting room can hear what's going on at the front desk. Is there a private space to talk if need be? That if somebody's in the waiting room and they have questions, or we need to talk specifically about their unique circumstances, can I bring them to another room where I can shut the door and have a private conversation that other people that might be sitting in the waiting room can't hear? So respecting privacy, making sure spaces are welcome, that they look welcoming. Have you ever walked into a doctor's office or a clinic and it's just all white walls, it feels very sterile, there's nothing but kind of medical posters up on the wall, and it's just not very warm and inviting. So things like painting the wall a warm color can do a lot to make your space feel more welcoming, or putting some local artists' art up on your wall can make clients and people that might walk into your building just feel more comfortable and like this is a welcoming space. If they walk in and your front desk workers, whoever's kind of greeting people, that they smile, that they greet people when they walk in the door and give them clear directions like, hey, can you come sign in over here, or use that kiosk or that computer over there to fill out a questionnaire, and kind of being warm and welcoming in their presence and their facial expressions and nonverbals. I think we've all probably walked in somewhere where nobody said hi to us, nobody even acknowledged us. They were busy working with their head down and didn't pay attention, and then kind of grunted at us to do something. And it just doesn't feel very welcoming and inviting. And for somebody who's experienced trauma, does that really invite them to want to engage in whatever services you're providing? I mean, I don't think so. So looking at all of those kinds of things can be really valuable. And what environment are you creating for clients to walk in? And what do you have control over to change? Some of us might be renting office spaces where we can't paint, or we can't put some, holes in the wall or something like that. So what else can we do? Can we have some comfortable furniture? Can we put a plant next to the couch or the waiting room chairs? Can we, make sure that the waiting room kind of smells nice or something like that, that it feels a little bit more welcoming with things that we can control. So the next principle here is choice. Oops. Choice is that we're involving the individual in choice and control. So individuals are provided a clear and appropriate message about their rights and responsibilities. So looking at your consent forms, looking at your client rights forms, are they easy to understand? Can you put them in a format like bullet points or something like that, that might be easier for somebody to read and understand? Can you post them like on a pretty poster or something in your waiting room so that people can always see what their rights and responsibilities are? But I want to be clear too, this is not just about clients, this is also about the staff and providers that we have working in our office. So if you are somebody in management or have a leadership role, then you might want to look at what rights and responsibilities do your employees have? Do they know what their rights are and what their responsibilities are? Do they know that they're expected to smile and welcome somebody if they're sitting at the front desk when a client walks in? Has that expectation been set and reinforced? Do you do that with your employees if you're in management? Do you greet them with a smile and with respect? Or do you act like you're too busy and can't be bothered? So this is talking about all aspects of the organization, not just how we treat clients. Because what we do know from research and other areas just within workforce is that if our employees feel respected and are happy and well, then they tend to treat clients and customers that way. It's kind of paying it forward in essence. So choice is important, and helping the person feel like they have a choice and that they have control over some things. Collaboration is the next principle. So making decisions with the individual and sharing power. So I think a lot of us know in the counseling world that it's a collaboration when we're working with a client. But this is also the case if we're employers and with our staff that report to us. Are we engaging them in the collaborative process to help them be better at their work, to help them succeed in the workplace? So how do we get feedback becomes really important. How do we get feedback from clients? Do we use things like satisfaction surveys or comment boxes? Or do we engage in like, getting a committee together to evaluate a particular thing within the organization and give feedback on it? Do we have like advisory councils or something like that where we can get a group of clients together and run an idea that we're thinking about for the organization, run an idea by them and get their feedback? How would they feel as a client engaging in this new idea, and what would that look like? So where are we getting feedback and input from the people that we serve, from our employees, from other stakeholders in the community? We might refer or collaborate with other entities like criminal justice system, Department of Child Services, other types of social programs in our area that might refer clients to us. How do we get feedback from them? So taking a look at where we're getting input from. And it's not just, complaints or grievances, but how can we get feedback that's both critical in nature, but also things that we're doing well? So as a counselor, am I talking to my client about what about therapy and working with me is helpful to them? What do they wish we could do more of? What do they wish we would do less of, or that they don't find helpful? So getting that kind of feedback and having an open conversation with clients can be really powerful and help them feel like they're part of the process, that they're collaborating and it's their treatment and that they're engaged in it. The next principle is trustworthiness. So is there task clarity, consistency, and interpersonal boundaries? So thinking about things like, as a provider, as a counselor, am I respectful and do I have professional boundaries with my clients and with my peers and other coworkers? So maybe looking at some policies and procedures in the practice, and are they being consistently upheld? Do some of them need to change because they're not working? So that we can be trustworthy and clients can trust us with their healthcare needs. But also from the management level, can your employees and staff trust your organization? Are you being respectful as a boss or a leader in an organization? Are you maintaining professional boundaries? Are you being clear in your expectations and making sure that your employees can meet those expectations, or are they kind of unrealistic and problematic and maybe need to change? And last is empowerment. So prioritizing empowerment and skill building and providing an atmosphere that allows individuals to feel validated and affirmed with each and every contact at the agency. So we all know it's really hard to be in a good mood all the time and to be happy and to be excited to engage with others. Sometimes we just have hard days. And so what do we do when the front desk person is just having a bad day? And maybe we can give them a break, and I can sit at the front desk so that I can ensure that people walking in the building and walking into the agency are still greeted with a smile, acknowledged, and welcomed into the facility. And that we also need to recognize that we all are humans and have bad days. And so when our front desk person is having a rough day, that we don't need to be grumbling and kind of put out to go sit at the front desk for 10 minutes or 15 minutes while that person takes a break. And hopefully that the same can be done for us too when we're having a rough day. So just kind of humanizing things a little bit, and perhaps there's some policy and procedures that need to shift so that we can work with everybody and still make sure that each person that's a client coming in, but also our fellow coworkers, or if we're in leadership, the people that report to us, that they're all seen as humans, and that we can kind of flex and give a little bit to empower people to ask for what they need, take breaks when they need it, perhaps. And that they're feeling validated. If you're in a leadership position, are you telling your staff that they're doing a good job when they are? Or are you just giving critical feedback all the time, which doesn't really feel good as an employee? With a client, same thing. Are you acknowledging their progress in treatment or validating that this is hard work that they're doing? Or are you just constantly kind of working on things with them, but not, helping them to feel validated or encouraging them in the tough work that we're asking them to do? So really these 5 principles kind of force us to look at our agency as a whole and everything about what happens when somebody walks in the door to, the treatment that we provide, to, helping them resolve their issue and then move forward in their journey. So it's kind of asking us to really pick through all of our policies and procedures and the type of experience that somebody has at our organization from beginning to end. So some things to think about in the physical environment and is on the left, and then the social emotional environment's on the right. So what does your parking lot look like? Your common areas, bathrooms, entrances and exits, are they well lit? Do people feel safe if it's dark outside? If they come in for an appointment in the morning or in the evening when it might be darker, do they feel safe coming to your organization or office? Decorate with warm colors and artwork so it's welcoming and feels welcoming. Create spaces for staff to relax. So is there kind of a common area that staff can kind of sit down and have lunch or have a cup of coffee, whatever? If you need security guards, are security guards readily available when necessary? Or are they taking a nap in the corner? Consider stationing your security guards at building entrances and exits to help monitor the flow of traffic in and out of the building, and also to welcome people at the door and kind of give them directions if they aren't sure where they're going. Keep noise levels in the waiting rooms low, or have some, kind of pleasant spa-like music, I think is always lovely. So it just feels more calm and relaxing in the waiting room. And so music needs to not kind of incite anxiety or stress. So loud music or music that is got a rapid beat to it would probably not be the best music to put in the waiting room. Use positive and welcoming language on waiting room signage. So whatever signs you have in the waiting room, pay attention to the language that's used. Ensure that people aren't allowed to loiter or congregate right outside the entrances and exits to your space. So if there's a smoking area where everybody congregates right outside the door to smoke, not only is that just sort of off-putting in general, but people may be uncomfortable walking through a group of people to get to the door. And if they're a non-smoker and they're coming, walking through smoke basically to get to the door, that can be just another barrier for somebody feeling comfortable and wanting to come and engage in services. So if you're going to have smoking areas, to make them away from the entrances and exits. And also that's where a security guard can come in handy if you have one, that they can kind of monitor that area and make sure people aren't just standing around congregating. Then the social and emotional environment. So train all staff, clinical and non-clinical staff, to effectively communicate with patients. So that's things like customer service, smiling, your nonverbals, welcoming people, saying hello, giving people directions, and maybe, looking at their tone of voice in the way that they communicate with people. Encourage, I just kind of said this, but encourage frontline staff, including front desk staff and security guards, to greet patients in a warm and welcoming manner and to acknowledge people when they walk in. A smile and a hello goes a long way. So it can be that simple. Understand how an individual's culture affects how they perceive trauma, safety, and privacy. So taking into account the culture in the community that you serve and what might make them feel comfortable or uncomfortable. It's always nice when we can send medical forms that require patients to provide really sensitive information. If we can send that to them ahead of time for them to fill out, that's really handy. A nice thing about electronic health records that many of us use these days is that we can do that, and we can have clients fill that out in a place that they find safe and comfortable when they're filling that out, rather than waiting to sit in the waiting room and for them to feel uncomfortable, or if they get upset, start crying, that may be very awkward and uncomfortable for someone, and maybe a barrier. They might leave, or not want to engage in services as a result. Asking the patients whether they are comfortable with having the door shut during exams or meetings. So again, this is being sensitive to somebody's trauma. Are they okay with the door being completely shut, or would they rather have it cracked a little bit? And again, that means that you have to pay a little bit of attention to how your office areas are structured. Can you do that and still maintain privacy and confidentiality while having the door open? Or what are the options for if somebody's uncomfortable with the door being shut? Keeping consistent schedules for services and what we offer, and offering clients sufficient notice and preparation when changes are going to happen. So if we're going to start closing on Fridays and not offering appointments on Fridays, that we've given advanced notice, and, maybe given a couple of months notice that, hey, in June, starting June 1st, we're no longer going to see people on Fridays. And so let's see if we can get our clients all scheduled Monday through Thursday. Or if we're doing, groups every Monday, Wednesday, Friday at 9 o'clock, and then we need to shift it to 11 o'clock, are we giving enough notice for everyone to know the change and be able to accommodate the change? Or if they can't accommodate the change, then what can we do to help them get connected to services that they can accommodate? So it's kind of thinking through all of these things and helping clients prepare, but also staff. A lot of us as staff and providers, we've had trauma too. So providing work environments where it's not just constant change is really helpful, that we can help our staff and our employees prepare and plan for changes so it can be executed successfully and that everybody can feel as comfortable as possible with the change happening. Some other ideas, some of which I've already covered, but something that's kind of become more and more popular in the workplace is to train all staff, regardless of their clinical involvement, but training all staff in trauma. So a lot of organizations have started doing mindfulness-based stress management trainings for their entire staff. So everyone from, janitors to doctors and everyone in between being trained in mindfulness-based stress management. Because it's not only good for working with the clients that we work with in our practice, but it's also good for us and helping us manage our stress. And when we're having rough days, what can we do to help ourselves stay well and be able to provide quality services to our clients? Or when can we notice that we are, perhaps starting to burn out and need to take a little break or take a step back? So that's becoming more and more popular, and they're starting to see the workplace cultures shift, that people are able to be less stressed at work, even though they might have demanding jobs, and able to manage that stress more effectively and not feel so emotionally burdened by the work that they're doing. Because, working with people with addiction and trauma can be emotionally exhausting. Clinicians or counselors, have a little bit more of a thick skin with that. We were trained in a graduate program that hopefully taught us about self-care and how to, manage our own stress and emotional responses to what might be going on with our clients. But a lot of our other staff, like, people that might work at the front desk or might work in billing or might work in, other roles at our agencies, they didn't necessarily get training like that. And that can be really helpful for them. And it just kind of shifts workplace culture to be more trauma informed and more responsive to stress and being able to manage that. And we all, working in healthcare is not stress-free, as we all know. So that can be a really great tool. Integrating trauma therapies into our treatment programs. So if we're, working in a addiction residential program, can we integrate some mind-body therapies like yoga? Or can we do some EMDR in our program? Can we do some trauma-focused CBT? Can we integrate some trauma therapies with our staff for wellness? So can we do yoga for the staff? Or maybe have a timeout room that's kind of, a calm, safe space where clients can go and perhaps staff can go there too. So thinking a little bit outside of the box around what can we do to not only provide some trauma therapy for our clients, but also recognize that staff may benefit from some of those things too. So if we can, do some yoga, then can the staff go do yoga as well as the clients? We talked about the adverse childhood experiences scale. Can you integrate that into your screening and assessment process? Number one, it can really help with identifying, obviously, childhood trauma that people have experienced and then help you from a treatment planning perspective. But it can also help you with looking at the culture of the client population that you see and how many What's their ACE number? You know, are most of your clients having 6 or more? And what does that mean for your treatment program? How can you integrate trauma therapy and trauma-informed approaches a little bit more because your client population just has a lot more childhood trauma? So that has impact for your treatment program. And also can help you with, you know, applying for grants or other types of funding opportunities if you can have some more data and numbers. And so compiling those scores to be used in outcomes or you know, funding applications you might apply for as an agency can be really helpful from the kind of that business perspective as well as from the treatment perspective. I talked about this earlier, but analyze how you receive input from clients and staff. Can you be a little bit more creative with how you get input and how you utilize input from clients and staff in performance improvement activities in the organization and in creating an organization that is more trauma informed from top to bottom? And then this is more of a self-care thing, but I really like this professional quality of life scale. There's the link right there that you can jot down. It doesn't take very long, probably 10-ish minutes to fill out the scale, but helps you as not just as a clinician, but can be an employee, just as an employee in general, regarding how you feel supported. If you're experiencing some secondary traumatic stress, if you are satisfied, if you're experiencing any moral distress and burnout. So that bottom bullet point, all the questions in the scale will, and it's an electronic scale, so it'll email you the results or you can kind of print them out from the screen. But it tells you kind of a score. Where are you at with compassion satisfaction? And then it gives you some tools and resources to look at that might be helpful. Where are you at with perceived support, with burnout, secondary traumatic stress, and moral distress? So if you've not taken it before, I would encourage you to take it. You can also take it multiple times. You know, you may take it now and then take it 6 months from now or something like that to see if you've improved. And it gives you resources under each of these headings. So if you are experiencing burnout and have a higher score in that area, there's some resources that you can access to help you manage that and deal with it. So it's kind of a actually really cool scale that gives you an idea of where you're at, and it's anonymous. You don't have to, if you want the results emailed to you, you put your email address in, but otherwise you don't put your name or any other identifying information. So it's just a nice tool to kind of do some self-analysis. Where are you at? And you might share that with colleagues too. Or if you're a supervisor, share it with the people that you supervise so they can pay attention to where they're at as well. Okay, I'm going to briefly talk about how addiction treatment can be re-traumatizing. And so incorporating some of these trauma-informed approaches can be really beneficial. So I'm going to pull all these up and talk through a few of them. I did address this in a previous training webinar, so whoopsies. So this may be redundant for those of you that might have been in a previous webinar. But some things that conceptually can be problematic when we're working with people with trauma is the concept of powerlessness, that they have no power or control over what's happening. Most people that have experienced trauma experience that powerlessness. And so it's not necessarily a comfort or a useful tool to be powerless with your addiction as well. It can be kind of re-traumatizing. Looking at the counselor as the absolute authority figure. So sometimes when we're in addiction treatment programs, we're in this role as a counselor of a disciplinarian as well, which can be hard because it kind of feeds into that authority piece. And people who've been traumatized don't generally respond to that very well because it's just not welcoming and it's not sensitive to the trauma. And so it can be a really kind of murky area for a counselor to be in this role of a disciplinarian, because you're working in a treatment program, and be a counselor. And so I think as counselors, we need to wrestle with that a little bit and figure out, how can we balance those things? Or is there another way to do this that can be more sensitive to trauma? Because most of your clients that are coming into your addiction treatment program are going to have a trauma history. We know that by the research. So being sensitive to that is important. Things like confrontation tactics, the way that we confront and challenge clients, can be re-traumatizing if we're putting them on the spot. Like there's an old tactic that we used to do in a treatment program that I worked at, where you'd basically put a client in the middle and all the other clients would give feedback and confront that person on their recovery, and are they working their recovery program, kind of problematic patterns that the other group members might see in that person. And so it's very much like putting somebody on the spot in the middle of the circle, all the attention's on them, and they're getting this really kind of negative feedback. That can be very re-traumatizing for somebody. So perhaps we can do that in a different way that's less overtly confrontational and more sensitive to the trauma. Some of the other things that we can look at if we're working in a treatment program that provides some type of consequence or punishment, for lack of a better word, consequence, I guess, is the best word. If you provide consequences for not meeting certain milestones, like for example, if they didn't do an assignment, what's the consequence of that, not doing that assignment? That there might be kind of a 3 strikes you're out rule, or they might be assigned something else, or they might have to do extra chores in the facility or whatever. Thinking through how we deal with consequences and how we can provide, perhaps we do need to provide consequences for a particular client, and what can that look like while being sensitive to the trauma that they've experienced. Oftentimes, people react in an aggressive way when they feel threatened or they feel like they're in a corner. And that's people who have experienced trauma can react aggressively because it kind of triggers that fight, flight, or flight response in our body, in our nervous system. So punishing aggression can be problematic and be re-traumatizing as well. Obviously, we need to do something if a client is aggressive, but punishing that can also be re-traumatizing because it's kind of a natural response with trauma that some people will respond aggressively when they feel like they're threatened. So kind of, not that we need to do significant changes to these kinds of things, but what can we do to be just a little bit more sensitive to the trauma and account for the trauma in what we do with clients. So it's not just, oh, you did this thing, so you're being discharged. But, is there trauma being triggered? Can we work with this client in a different way that might be more sensitive to the trauma and might help them move towards healing and recovery rather than just kicking them out of a treatment program? Obviously, sometimes that's not possible, but, can we kind of think outside the box with some of these concepts and be more sensitive to the trauma? So this is kind of relating all of these issues that can be re-traumatizing to what we can use within the principles of the trauma-informed practice. So if it's punishment, then let's look towards safety, the safety principle, and what can we do to instill safety with clients? If clients aren't trusting us, what can we do to increase trust? Instead of confrontation, can we engage in some collaboration with clients? Instead of being authoritative, can we engage in choice and empowerment? So instead of compliance, can we work towards healing and transformation with a client? So it's kind of challenging us to just shift our paradigm a little bit to being more collaborative with the client, reinforcing choice and empowerment, and creating an environment of safety and trust so that they can transform and heal. Some other things to think about, we might include some DBT in our treatment program that helps people learn mindfulness strategies and emotional regulation and manage stress and distress, very similar in nature to the mindfulness-based stress reduction or management, depending on what you call it. Trainings, DBT kind of gets at some similar principles, so we can integrate that into our treatment programs to help people manage trauma responses as well as their addiction related responses. We talked about trauma as being stored in the body. So can we incorporate some mind-body elements into our treatment program? Can we incorporate some breathing, some movement, maybe some rhythm? Can you maybe include some music therapy, some yoga? And here's some other plenty of options. Art therapy, drumming or sound healing, mindfulness, EMDR or brain spotting, some theater, improv, psychodrama, sensory motor techniques or somatic re-experiencing techniques, neurofeedback, Reiki, tapping, advanced integrative therapy or AIT, acupuncture, massage therapy. This is not an exhaustive list by any means, but just some things to think about. Are there other ways that you can include some body-based interventions that can help people work through their trauma and also thereby working through addiction as well, and really make this a truly integrated process? So those are just some ideas for you to think about. You may or may not be able to incorporate these in your practice, but again, how can we be creative to meet the needs of our clients in the best way we can? Okay, so that was your crash course in trauma-informed approaches. And if you have questions, I don't see any questions specifically in the chat, and we only have a minute left. So if you will, those of you that did not have a name on your little box on the Zoom, if you could send a private message to Kent, then he will be able to mark you down for attendance. Then you will be receiving a satisfaction survey along with a little post-test questionnaire, just 5 questions to answer. And once you fill that out and submit it, then you will get your certificate for your attendance today that you can use for continuing education credit. And you'll get that within 24 hours after you submit your survey. So thank you all for coming today. I hope you have a wonderful weekend. This is being recorded, so it will be on the CADA website to review later if you would like. And I hope to see you soon in a future webinar. Thanks so much. Bye-bye.